I have never met a woman who hasn't been directly impacted by breast cancer. This is unfortunately a common diagnosis, and it will touch our lives if it's a friend, a sister, an aunt, a grandmother, or even a daughter.
When it comes to reconstruction, knowledge is power, and Dr. Camille Cash is here to deliver both.
When a woman is diagnosed with breast cancer, it's obviously very traumatic. It is devastating because women will be losing a part of them that identifies them as a woman. You're trying to figure out, how did this happen? How do I survive? How do I move forward? How am I going to feel as a woman? It's also a spiritually devastating diagnosis.
We're talking about breast reconstruction, which isn't just about appearance. It's about healing, choice, access, and identity.
I want to make sure that women are aware of their choices. No, reconstruction is still a choice. You have to make the best decision for where you are in your life, in your mental space and capacity, as well as in your treatment plan.
And for many Black women, that access hasn't always been equitable.
Education is huge. Organizations like Sisters give me hope because you all are educating the communities. We're hoping that's changing 1 year at a time. It is. Recognizing that you have the right and the opportunity to grieve that loss is a powerful opportunity. Ladies, it is so important for you to do your breast exams and for you to get your mammograms. It could literally save your life.
Welcome back to another episode of Sisters in Survivorship podcast. I'm Caleen Allen, Executive Vice President with Sisters Network Incorporated. I'm so happy to have you here today. You know, we're talking about breast reconstruction, which isn't just about appearance. It's about healing, choice, access, and identity. And for many Black women, that access hasn't always been equitable. Here to talk a little bit more about breast reconstruction in general is Dr. Camille Cash. She is a board-certified plastic surgeon based in Houston, Texas. She is also a member of our board of directors for Sisters Network, so she lends a lot of guidance to our organization. And she's a nationally respected voice in the breast reconstruction space. Dr. Cash, thank you for being here today on Sisters in Survivorship podcast.
Thank you so much for having me.
Tell me a little bit about yourself and your practice.
So I've been, it seems almost 24 years now in private practice here in Houston, Texas. I started kind of the first Black female plastic surgeon in the state, opened up my own shingle, and at the beginning of my practice did a variety of different procedures, so both reconstructive and cosmetic. So looking at patients after breast cancer and helping them with reconstruction and marrying the principles of reconstructive surgery also with aesthetic or cosmetic surgery, because we know that each side of plastic surgery blends itself into each other. So it's not just reconstruction or cosmetic, they're actually a fusion of the two procedures and concepts.
Okay, and I know we mentioned that you're board certified.
Yes.
Tell us a little bit about what that means. And I know that you did make history at one point being double board certified.
So when I finished, the training to become a plastic surgeon, I did 4 years of medical school, and then I entered into a 5-year general surgery residency program. And at the end of that residency, you're board eligible. And I went straight into plastic surgery residency, but I still completed my boards in general surgery. So what that looks like is you take your written board examination. So it's a kind of a test where you go and you sit down and you take it. Back in the day, we all flew to regional locations. I flew to Dallas and I took this board examination, the test on general surgery. Then a year or so later, I sat for my oral board. So that's where you go in and you sit in 3 rooms in front of 2 or 3 examiners, and they grill you and ask you questions.
Oh, wow.
They give you scenarios and things of that nature. So
you got to be really ready.
You have to be really ready. And it was a challenge because I was taking my general surgery boards when I was training to be a plastic surgeon. So it's kind of always better to do it when things are fresh. So I went straight from general surgery into plastic surgery. But during that first year of plastic surgery, I'm taking my general surgery boards. And then during my second year of plastic surgery, I'm doing my oral boards for general surgery. So I became board certified in general surgery. And then when I finished the 2-year residency of plastic surgery, I then did my written boards for plastic surgery. And it's funny because my general surgery boards, my oral boards, I delayed for a year because my second child. My written boards for plastic surgery, I took 2 weeks after my son was born. So I would take it when testing centers first became a thing.
Okay.
And I would go out in the middle of the exam on my breaks to pump. So
just a working
mom.
Working mom.
And then the second part of boarding in plastic surgery is to take an oral examination. So for plastic surgery, you have to submit the cases that you've done for the first year and a half after your written exams. They get selected, and then a few cases get selected for you to be examined on. In addition, you do, again, 3 rooms, 2 or 3 different examiners, scenarios, case presentations, and they want to know how you'll handle it. And then they want to know how you'll handle it again when things don't go the way you expect it to. So very stressful.
A lot involved.
It's a lot
involved. Let's talk about when you have patients that you see, and I know you do all types of plastic surgery, and we'll talk a little bit more about that, but I want to focus right now on breast.
Sure.
For women who are doing reconstruction because of having a breast cancer diagnosis, talk to me a little bit about what that process looks like. When do you enter into the conversation?
Sure.
The before, during, and after.
So really, it can be variable. When a woman is diagnosed with breast cancer, it's obviously very traumatic, it's very stressful. And they're typically seen by a breast surgeon or maybe a medical oncologist first. And the oncology doctors, the surgical oncologists, as well as the medical oncologists, their goal is to treat your cancer. And sometimes that is their main focus and less focused on their reconstructive options.
Okay.
In some centers, there's a collaboration between specialties. So you'll meet with a breast surgical oncologist as well as maybe a medical oncologist, maybe a radiation oncologist. And in that collaborative environment, oftentimes you should be invited to meet with a plastic surgeon to discuss your options.
So tell me about, does that happen frequently, or?
Sometimes that it doesn't always happen because depending on, I guess, which surgeon you see, they're typically going to be the driver. And so I think it's important for women to be educated about their choices, because I've had women come to see me for reconstruction and we start talking about different options, and breast reconstruction then becomes a very complex decision-making process all of its own. In the interim, patients are typically emotionally reeling from the diagnosis of breast cancer. So it can be a lot to digest and take in, but as a plastic surgeon, I want to make sure that women are aware of their choices.
And it's covered after you've been diagnosed.
It is covered. There is a Women's Health Care Act that was passed in Congress in the 1990s that covers breast reconstruction by insurance. Insurance companies, including Medicare, are mandated to cover breast reconstruction, not only at the immediate time of diagnosis, but subsequent procedures in the future. So if there's something that needs to be revised, it also importantly covers surgery on the other breast, so the non-affected breast.
Really?
So that is something that women need to understand, that it is covered by insurance. And say you're having surgery on one breast and you're going to have that breast reconstructed, and say it's your right breast, then you want, as a plastic surgeon, we want you to have the best symmetry, or we want your breast to match. So that means that the insurance companies are obligated by law to cover whatever procedure you need to have done on the left breast. And that could be anything from a breast implant to give you balance, a breast reduction, a breast lift, or in some cases, women may opt to have their non-affected, their non-diagnosed breast removed to prevent future cancer. And then you're eligible to have both breasts reconstructed.
Okay. So let's talk about when a survivor does make that choice of having the reconstruction. Do they have to do it immediately? Can they delay it? And also, can they use their own tissue?
Sure. There are lots of different choices, which makes that even more complicated conversation. So first and foremost, we want patients to understand that we want their breast cancer to be treated adequately. And that may be starting with the breast surgeon. That could be a lumpectomy or just removal of the mass itself, plus or minus radiation, or it can mean, in order to give you the best chance of survival, a total mastectomy, meaning the entire breast is removed. Then there's also subtle nuances as we do mastectomies. Are we able to save the nipple? Are we able to save some of
Oh,
the markers, the anatomic markers that identify your breast as a breast, right? So it's not
okay.
just a lump of tissue. It's got a nipple. It has the pigmented tissue around it called an areola. It's got shape. It's got folds. It's got volume. It's got, movement. And those things are things that plastic surgeons, we think about on a daily basis. But your surgical oncologist and your medical oncologist may not think about that. So understanding what type of treatment for your breast cancer is appropriate then helps plastic surgeons to guide you into making the best choice for a reconstruction. Obviously, the best thing is to not get breast cancer. The second best thing is to have an early breast cancer. When you have an early breast cancer and you take care of that diagnosis, then there opportunities maybe for the oncologist to take less tissue and more opportunity for reconstruction. So you decide with the surgical and medical oncologist what's the best treatment to cure your cancer
First.
first and foremost. And that may be just simply surgery. It could be surgery and radiation. It could be chemotherapy first,
Hmm.
and it could be a combination of all of those involved.
Sure.
But to answer your question, does it have to be done at the diagnosis? It does not. You can have your breast cancer treatment and then heal from that both mentally and physically,
And that's the key word, mentally.
and then you can come back in the future and have a breast
So
reconstruction.
there's no window of time.
There's no window. There are certain benefits to having a breast reconstruction done at the same time as your cancer treatment. But I think the breast surgeons are and the plastic surgeons work together to try to give you the best outcome if it's a delayed reconstruction. And I always tell patients this: there's always the option not to do reconstruction.
Oh,
And that is a viable and important choice for women. It is about choices and for you to be educated. Breast reconstruction can be complicated. Breast reconstruction may require multiple procedures. A reconstructed breast doesn't always look or feel like your natural breast. And those are limitations that plastic surgeons are constantly working to improve. But the reality is, we're not quite there yet. So, my goal is to educate patients to understand a choice is sometimes to say no.
hmm.
And then you can always have the choice to come back and say yes in the future. So, there's just different ways to approach how your breast is treated to deal with the cancer. And that will dictate how we, as plastic surgeons, help you reconstruct what's lost.
So if someone has implants and they are diagnosed with breast cancer,
Yes.
how is that handled? Do they have to come to you first and have them removed, or?
So oftentimes, if a patient has existing breast implants, they've had it done for cosmetic purposes years ago, and now they have a new breast cancer diagnosis, it's typically that is a situation where I think that the surgical oncologist should still meet with the plastic surgeon in advance. That doesn't, again, always happen.
Mhm.
The general surgeon, the breast surgeon may just decide we're taking this implant out and it's in the trash. The question then becomes what happens after surgery with your treated breast in comparison to the other breast. So there's a lot.
Mm.
Breast reconstruction is a very complicated and nuanced, procedure.
And
Procedures.
process, yeah.
Yeah, it's a process. And so I try to tell patients there's ways that we can break breast reconstruction down into categories. The first is immediate reconstruction versus a delayed reconstruction.
Okay.
Immediate means we're going to do your breast reconstruction at the same time as your cancer treatment. Delayed means we're not. And that delay could be weeks, months, or even years.
Okay.
Then we talk about, again, categories of types. Is this going to be an implant-based reconstruction, meaning we're going to use a breast implant or a tissue expander to create the shape and the volume of the breast?
Hmm.
Or are we going to do an autologous reconstruction? And autologous means auto means from you, meaning we're going to take tissue from another part of your body
Hmm.
and use that to reconstruct your breast. So immediate versus delayed, implant-based versus autologous reconstruction. And that is how, just general ways to think about that. And again, pros and cons of each. So with an immediate reconstruction, the tissue planes are fresh, meaning the breast surgeon's going to go in and, for a lack of a better word, scoop out your breast tissue, just like you're hollowing out a pumpkin. So
Oh.
it leaves the outer shell or the outer skin, the outer folds of the breast still available, and they're fresh, meaning they haven't scarred down after surgery. And allows the reconstructive surgeon to fill that and shape that new breast. Delayed reconstruction means the breast surgeon's going to take that tissue out, sometimes take more skin, or leave more skin if they know you're going to come back for a reconstruction in the future. And then another nuance is, at the time of the mastectomy, there's sometimes the plastic surgeon will leave what's called a tissue expander or a spacer there.
I hear a lot of our patients, or rather our members, talking about the expanders, and
Yes,
they have to leave them in for a certain period of
correct.
time.
So the benefit of an expander is it's allowing the plastic surgeon to put something into that space. And it allows the skin envelope, like I said, breasts have shape, have curves, have folds, and that expander helps to preserve some of that tissue and some of the contour of a breast. May not be
Mm.
perfect, but it allows the plastic surgeon to save that. Tissue expanders can go in, and they're not inflated, meaning they're not filled to the capacity to create shape, but they can be left empty. And the reason for that is complicated, but leaving a flat expander allows the mastectomy skin to heal without putting too much pressure on it, which can lead to wound healing issues. It can also allow the tissue planes to heal in case you need to have radiation. And they can radiate the skin flaps without the presence of a fully expanded tissue expander or implant. So it
Okay.
allows that radiation therapist to kind of get into all the nooks and crannies of your skin envelope. And it can just serve as a spacer. And that tissue expander can sit there for 3, 6 months, or even longer.
Hmm.
Most patients like to get them out after about 3 months because
Hmm.
they can be, they're thicker devices, they're firmer. They have typically a magnet, so the plastic surgeon can fill that implant or that tissue expander without popping it or putting
Hmm.
a needle in the wrong spot. So they can be uncomfortable, and so you may hear patients talk about those tissue expanders being uncomfortable because it is a
Sure.
thicker device.
Okay. How does radiation factor into, you know, with reconstruction
Sure.
or implants and so forth?
So plastic surgeons and radiation oncologists, we're not really friends. We kind of, we're opposites. We have the same goal. We want to treat patients and we want to make sure that their survival is enhanced. But what radiation does and how it works to treat cancers is it basically shrinks blood vessels, or kind of destroys some of that microcirculation. So, meaning that circulation, that oxygen supply, the
Hmm.
nutrient supply to cancers is cut off. It destroys cancer
Right.
cells, but it also then acts as a protective measure to decrease nutrients from getting to where old cancer cells used to be. Well, that's great for cancer cells, but it's not great for your tissue because
Or I
at the
would think the skin as well outside,
yes, the
yeah.
skin, the muscle, the ribs, anything that's being touched by radiation, which is the job of the radiation
Sure.
doctor, to minimize the amount of radiation they need to treat your cancer. But it causes decreased blood flow to the skin. So that means skin can be stiffer, it can be more fibrotic. So as plastic surgeons are trying to reconstruct your breast, it may mean that a tissue-based implant, or an implant-based reconstruction may be more prone to have a firmer breast, a harder breast.
Okay.
And in that situation, if you're having a significant amount of radiation or radiation at all, then oftentimes a better approach for you may be an autologous breast reconstruction, meaning a tissue-based reconstruction, not an implant-based
Because it's
reconstruction,
going to give you the.
because you're going to use the tissue,
Hmm.
the skin and underlying fat and whatnot, to replace some of that radiated tissue and to bring in fresh tissue underneath the surface of the skin so it's softer, as opposed to an implant that's sitting under maybe radiated or firm skin.
So we talked about ladies who, who have breast cancer and then also those who have implants. When they have implants or when they've had the reconstruction, how does the screenings moving forward
Sure.
or, when you just have your implants, what's the best protocol for folks? Because I've heard some people say, I don't have to have a mammogram anymore because I've had both, I've had a mastectomy
Sure.
and I've had the,
Sure. So if
mhm.
you're a cosmetic patient, just say you had your breast implants for cosmetic purposes when you're 25. I tell patients you still need to have one monthly breast exams, period, all of us. And then once you hit that age 40 or earlier, if you have a family history of breast
Mhm.
cancer, you're going through your mammograms. So even with breast implants in patients who have not had a cancer diagnosis, you're doing your mammograms. And the mammogram technicians understand if you have implants that there's different procedures that they do to displace the implant so they can focus on your breast tissue. So breast implants for cosmetic purposes have never delayed a diagnosis of breast cancer. There's no studies that support that. And so patients that get breast implants for cosmetic purposes still need to go through the regular screening. Now, let's just say that you've had a unilateral mastectomy with an implant-based reconstruction. In that situation, technically, the breast tissue on that reconstructed breast is gone. So some doctors may say you don't need a mammogram because there's no breast tissue to image. You'll still need a mammogram on the other breast. Because the other thing that I tell patients, and sometimes they don't recognize, is one of the number one risk factors of breast cancer is having a previous breast cancer. So if you have breast cancer once, there's an increased risk that you could have breast cancer again in the same breast or in the other breast. So
Okay.
I think that's important for patients to understand, is that this is a lifelong surveillance for patients. So if you have an implant-based reconstruction on one side or a tissue-based reconstruction on one side and a natural breast or an implant breast, you still have to do mammograms on that natural
Natural
breast.
breast. Okay.
Very important. Now, if you have bilateral, you've had both breasts removed and reconstructed, the idea is that, again, all of your breast tissue has been removed.
Hmm.
And so mammogram may not be the best imaging study to monitor your breast. That can be done through physical exam, sometimes ultrasound, or
Okay.
even MRI.
Okay. That's good to know. And you mentioned the Women's Health and Cancer Rights Act. Do you find many Black women are aware of this law as you've encountered or?
I think women sometimes have a vague understanding of breast reconstruction. And we have a awareness of breast cancer because of all the great advocacy that's been done.
Mhm.
But it's important for women to understand equally that if a diagnosis of breast cancer is made, that there are options that are covered by your insurance. So I think understanding that. There's definitely disparities in breast reconstruction. If you, Black women, Latin American women, Asian women have a lower rate of reconstruction as compared to white women.
Mhm.
It's historical knowledge.
Mhm.
It used to be There's used to be a lot of different reasons, theories of why that is, but it can be access, it could be communication, it could be just barriers to entry. They found that there is a lower rate of reconstruction in Black women, regardless of socioeconomic status or insurance status.
Oh, that's
It's
interesting.
interesting, right? So it's not because we're poor or it's not because we don't have access. Even women with access are being are adopting rates of reconstruction at a lower rate than white patients.
And so if we're not thinking maybe it's so much access, it's knowledge, or is it just fear, or is?
I think it's education. I think it's also important for physicians to recognize the role that we play in offering reconstruction for all patients and not assuming that a patient may or may not want to have reconstruction. So I
Mhm.
think there are still ways that as physicians we can make sure that we're communicating with all of our patients
Yeah.
their choices and watching for any barriers to entry for patients.
What do you say to these young women who are coming in with breast cancer? Because we're seeing, of course,
Yeah.
the alarming number of young women being diagnosed. And I would assume that they are more likely to come in and seek that reconstruction more often, I would imagine.
I think it's a varied. The young women sometimes present with the worst cancers. That's what's really scary. And those women, I think the focus sometimes is just on surviving because their diagnosis is often delayed because nobody thinks a 20-year-old can get breast cancer, but they can.
Hmm.
Nobody thinks that the 30-year-old is going to need bilateral mastectomies, but they may. And I think understanding that breast cancer is something that isn't limited to just women of a certain age, recognizing the importance of breast health for women, understanding how to examine your breast, what feels normal, what feels different, and also being an advocate for yourself. So if you know that something doesn't feel right, stick to your guns and seek someone who's going to listen to you. And mammograms are not always the best imaging study for young women because young women's breast is historically more dense when they're younger. Ultrasound or combination, and every woman in America and beyond needs to be getting a 3D mammogram. 2D mammograms, old technology. It's like
Absolutely.
it's like using a flip phone.
Say that again.
Nobody uses a flip phone. So why is anybody getting a 2D mammogram? They just need to be eliminated and replaced. And if you're in a community where for whatever reason that's all you have, 2D mammogram and ultrasound. But nonetheless, understand your body, pay attention to your body, and advocate for your body. Because yes, unfortunately, we are seeing young women with devastating diagnosis of breast cancer.
And it very advanced.
Advanced because it can be aggressive, and it can be delayed in diagnosis because, again, people think, oh, you're too young to have breast cancer.
Right. I can't emphasize enough about the 3D mammogram.
3D mammograms.
You know, as Sisters Network with our breast cancer assistance program, we, of course, provide financial assistance, but we also pay for mammograms for women.
Yes.
And our policy is we will only partner with, facilities that will give the ladies a 3D. Mrs. Jackson is adamant that that's the
Yes.
latest, greatest. That's all she wants for herself and
Exactly.
anybody in her family. That's what she wants for the ladies in the
Correct.
community. And so thank you for, again, reinforcing
no.
that 3D is the latest, greatest,
For
and
sure.
every woman should have access to that.
Correct. And my other point that I make is breast exams, self-breast exams every month. Especially when you're young and your breasts may go through some hormonal changes, figure out what your breasts are supposed to feel like.
What's your normal?
What is your normal and how things change? And I think that is something that I stress because oftentimes if you're young, you're not at the age for a screening mammogram.
Mm-hmm.
But if you feel something that feels just, if you physically feel something, you touch your breast and you feel, I don't know, this wasn't there maybe last month, or is this new? See your doctor, advocate for yourself, and understand what is the norm, because you're not necessarily going to be going for a screening mammogram. So you have to be the one that's advocating and paying attention to your breast.
And why is equity so important?
Well, equity and is the opportunity for all patients to have equal access. And if you don't have equal access, then your diagnosis is going to be delayed, your options are going to be less, and your survivorship or your survival rates may be less. So it's important for everybody to have equal access to the best types of care, and that includes that 3D mammogram.
And just let me touch a little bit on healing after the reconstruction. Just how does like Black skin heal?
Sure.
Like, does it, the darker skin tone, the scarring or anything like that? Because I think that's important.
It is important. And I think surgeons need to understand that there's nuances in skin of color. Let's just say skin of color. So that's Black women, because we know Black women, we come from all sorts of backgrounds and racial mix and things of that nature. So you've got Black women, you've got Asian women, Latin American women, women of African origin, like, you have African American women. We're all kind of like interspersed in the diaspora. So our gene pool kind of gets mixed up. Skin of color just means that is color that not only has variable pigmentation, but the also definition is that our melanocytes, our pigment-producing skin cells, tend to be a little bit more reactive.
Mm-hmm.
Our inflammatory response may be a little bit more hyper sensitive as compared to patients who don't have skin of color. That means we may form scars differently.
Mm-hmm.
That does not mean every one of us is going to make a bad scar, or every one of us is going to have a keloid, or every one of us should
Right.
forego reconstruction because of that risk. It's important for surgeons, plastic surgeons, to understand how to handle skin of color, how we perhaps maybe need a little bit more attention after surgery in terms of scarring.
Right.
But as a plastic surgeon treating patients of color for 24 years, there are certain nuances, but it doesn't mean that we shouldn't have surgery because there's a slight risk of healing differently than our white counterparts. There are ways that we can counteract that, but it's important for patients to understand what a scar is and what it will look like and how it may change with time and how it may vary from patient to patient.
And what about like the numbness and the sensitivity,
Yeah.
especially from the intimacy side of
Sure.
things?
So that is a frontier that plastic surgeons are looking to address. In fact, I have to do a little plug here. So my daughter is in medical school,
Yes.
and she's in medical school at Columbia. And one of her actually, the focus of her research here has been on neurotization, or providing sensation to women after breast reconstruction.
Oh,
So they're
go Lauren.
Go Lauren. Well, and Dr. Christine Rohde, of course, we have to
Yes.
recognize her.
Yes.
But the idea is a breast is more than just a lump. It's more than just a shape in a bra. It is a sexual organ. It is an identifying and part of self-identity organ, or body
Absolutely.
part, or however you want to call it. And with the more traumatic your mastectomy is, the more involved your reconstruction is. And I mean traumatic in a way of surgery.
Mhm.
How much skin they have to take means they're taking away nerves, they're taking away blood vessels, and that does change the sensation of the skin envelope. So your breast may not feel like a breast. Your reconstructed breast is going to feel different than your native breast. And that is something that patients need to be educated on so that they can be prepared for
And have
that
realistic
change. Yeah,
expectations.
realistic expectations, and understand it may not be perfect, but it's certainly, trust me, better than the option of not having a breast.
Mhm.
So there are techniques in which plastic surgeons are working on reconnecting nerves, improving sensation.
Wow.
There's also a focus on lymphatic anastomosis to decrease the risk for lymphedema,
Lymphedema is
which
real.
is very real.
Can you get that in your with breast
So
reconstruction?
you typically don't get it in the breast, you get it in a limb.
Ah.
So it's from the removal of lymph nodes.
Mhm.
It can be not just removal of lymph nodes, but just radiation in the
Mhm.
axilla, different trauma where your lymph nodes kind of come and drain fluid out of your body, and they kind of have lymph nodes, main circulation in kind of your underarms.
Because it
and your
can become a
groins.
very
It
debilitating
can be
situation.
very debilitating.
Yes.
Patients can have, swollen extremities for life. So there's wonderful work that's being done by microsurgeons on lymphatic anastomosis to treat that. So
Wonderful.
we're recognizing the limitations and working to improve them.
Oh, that's wonderful. Just want to touch on a couple other things. I know that we talked about family history, and so some women, because they have the BRCA gene or family history, they've opted to do, I believe it's called prophylactic.
Yes.
And so, talk to me about a little bit about that. Are you seeing women coming in
Sure.
or exploring that option?
Definitely. So we have identified two genes, the BRCA gene, BRCA1 and BRCA2,
Mhm.
that are the genes that are identified with an increased risk of breast cancer. However, there are familial patterns of breast cancer that a gene hasn't been identified for that. But there are sometimes women who maybe have a strong family history or a BRCA gene, and they will have what's called a prophylactic or a preventative mastectomy or bilateral preventative mastectomies. Maybe they don't have any any diagnosis of breast cancer, but their risk is so high that they decide to have both of their breasts removed. So I think that Angelina Jolie is been very public about her diagnosis and her option. And so that can be, hey, listen, I know that this is a possibility, it's a high risk, and I'm going to have both of my breasts removed and treated, so that reduces my risk. And that is something that we do see for patients. We also see patients that, and I do tell patients, there is because like I said earlier, there's a risk once you have breast cancer, there's an increased risk that you'll have it again or have it in the other breast. So just sometimes that is another option where it could be a woman that's coming in her 30s or 40s. She's young, or she has a young family and she has children to take care of, or she just wants to go, you know what, I really want my risk to be reduced to the lowest level that I can, and they will opt to have bilateral mastectomies.
So they can't breastfeed after that either, right?
No, they cannot. So when the breast tissue is removed, even if the nipple coverage from the skin is left behind, all of the breast tissue is removed, so they would not be able to breastfeed in the future.
Okay. What do you wish every Black woman would think about if they're diagnosed with breast cancer as it relates to reconstruction?
I would like them to know that they have options and choices, and that even though the diagnosis of breast cancer is very overwhelming and the treatments plans for the cancer are overwhelming, they still have the right to know about their reconstructive options, even if they decide they don't want to do it. And they need to understand that it is covered by insurance, by law, for their entire life. So those are things that patients need to be aware of.
And that's where you follow up.
That's where you follow up. Yes.
Yeah. And what gives you hope in terms of on the plastic surgery front, and again, as we talk about the Black community?
Organizations like Sisters give me hope because you all are educating the community. So the first and foremost thing is to educate, so patients are aware, so that they can get their screening, they can be knowledgeable, they can talk to their aunties, their grandmothers, their daughters. Education is huge. So that is what's helpful, because we can hopefully continue to get earlier diagnosis. From a plastic surgery community, I am just proud of the fact that we are continuing from a technical standpoint, pushing the envelope of improving outcomes. So it's not just giving you a lump of mass, but we want to shape it. We want it to be sensate if possible. We want to deal with lymphedema. We want to treat this, as I said earlier, like it's an aesthetic or a cosmetic procedure, not just a reconstruction and any old breast will do. So that does give me hope. I think that watching my plastic surgery organizations support breast cancer patients, and both of the organizations that I'm involved with, the American Society of Plastic Surgeons as well as the Aesthetic Society, both have fundraising efforts for breast cancer awareness. And importantly, the Aesthetic Foundation also has a breast cancer assistance fund.
Yes.
And it's funny because I was at a board meeting in which they said, we're the only organization that does this. And I said, nope, nope, no. Let me tell you about Sisters Network, because they've been doing BCAP funding for women for years, well before the organization. But I am impressed that the the Plastic Surgery Society and the Aesthetic Society, which I'm involved most actively in, recognizes the need for women and provides financial assistance while still funding opportunities for reconstruction for patients. So that gives me hope that we're continuing to push the needle forward. We're not afraid to talk about patients' needs, diversity, recognizing that the breast is a sexual and a identity organ, not just a lump.
And then it's always nice to see someone who looks like you when you're coming in for, medical care, and it just gives you a level of a safe space.
Correct.
So tell me a little bit about the diversity in the plastic surgery world that you navigate with your wonderful colleagues.
Well, I will say that we're getting better in terms of diversity. I was, as I said, the first Black female plastic surgeon in the state of Texas, and that was 24 odd years ago. There are more of us.
And that's not that long ago.
That's not that long ago. There are more. There are actually 4 of us practicing in the state now, but that's still not a lot.
As compared to what?
Yeah, exactly. As compared to 30, 40, 50, 60 beyond plastic surgeons. So,
So less than 10%.
oh,
Less than 1%.
we're less than 1%. African Americans are definitely less than
Wait, less than 1% across the
plastic surgeons.
across the board?
Mhm.
Wow.
And I'm hopeful because there are more of us out there now
Mm-hmm.
than there were before. So that's very important.
And like you said, your
It's
daughter's
hopeful.
following your legacy.
Correct.
So we have
Correct.
future coming up.
And I think it is important, with social media, with media presence, I've always been out there, and seeing somebody, like you said, that looks like you, that paves the way, that shows that, oh, it's possibly to be a plastic surgeon. I'm a woman of color. I'm a man of color. I've never seen a plastic surgeon that's looked like me. I've never seen a plastic surgeon ever, but there's still that guide that is possible. It is a lot of work. It is very competitive, but it is possible.
And then lastly, you're big on social media.
Yes,
the real Dr.
the
Cash
real Dr.
is
Cash.
her handle on IG. And
Yes.
so talk to me a little bit why you feel like you want to use that platform to get out there, and you got some creative stuff going on your socials.
It's social media has been just an ever evolving animal, and before social media, I was big into education, right? Just talking to patients, talking to the public about plastic surgery and the opportunities. And as of course social media has expanded, and at the beginning it was funny, I used, as many businesses used it, as a way to market myself, as a way to educate patients, attract patients to my practice. And then I started, then right around 2020, COVID, George Floyd, this whole idea of DEI and the reckoning that we went through for a short period of time in this country. I remember talking with my Allergan rep, my Botox rep, and she was like, there's so many more women of color, providers of color in the aesthetic space. And I was like, really? Because I've been just kind of in a silo by myself, and I've been the only one for so long. I didn't realize that there's so many more young women, men that are interested in getting into plastic surgery. And so I went to a national meeting in, of course, of all places, Atlanta, and I walked into this event, and it was an event that was held by different affinity groups within the plastic surgery community. So it was a women of color plastic surgery. It was Times Up PRS that was looking at, unfortunately, women who have been sexually abused, intimidated, or harassed. And then there was the Women in Plastic Surgery organization. So all these affinity groups. And I walked in the door. I was a little late flying in, and I walked in the door, and it was very humbling. But I had young men and women kind of coming up to me, Dr. Cash, we're so happy. Can I take a picture with you? And I'm like going, why are you taking a picture with me? It's all good. But I'd been on social media for so long talking to patients that they recognized me.
Wow.
And it was important for me at that instance to realize that is, as somebody who's been very blessed and fortunate to have the career that I've had, it is really important for me to give back and to be a role model and to be accessible. And I have mentees that will come, and they may spend a day in the clinic with me, or a day in the operating room, or I may just talk to them on the phone. I have mentees from Canada, from New York, from Florida, all over the country, and then obviously now in Canada as well. And I meet young folks that want to go into plastic surgery, and if I can just stop and give them a minute or two just to say, hey, you can do it. It will be hard. It is hard. It can at least open that door for somebody that maybe didn't think it was a reality.
I know that there's a small percentage of Black women who are plastic surgeons across the United States. What does that look like right now?
So if you look at the population of the United States, African Americans make up about 13-14%. When you look at Black plastic surgeons make up 4% of all plastic surgeons. Black women plastic surgeons make up 1.7% of all plastic surgeons. So we're vastly underrepresented in the field of plastic surgery.
But we're hoping that's changing.
We're hoping that's changing 1 year at a time. It is. It's slowly changing.
Okay. Well, thank you for shedding some light on, reconstruction and equity and just understanding that process. So I appreciate all that you do. And of course, we appreciate you being a board member for Sisters Network.
My pleasure. I always
Thank you.
love that. Thank you so much.
The motivation working in oncology is easy. I think we all have a family member or a friend that's affected by cancer, and you just know the toll that takes on not only that person, but their family.
While I might not today be in one of those situations where I desperately need a medicine for someone I care about, millions of people are all over the world in that exact situation. Like, we are the people who make those things.
No shortcuts, no compromises. We discovering, we identifying, we applying cutting-edge technologies and the methodologies in our daily work.
Whether I can improve with new technology, doing something faster, I'm always trying to get better in every experiment that I'm running.
I think we constantly have to be pushing those boundaries, not just so that we can stay at the forefront as a science and technology company.
Being bold with ideas can really help us make breakthroughs and bring us step closer to discovering effective treatments for patients.